We can hear you, sir. So I shall start the program now.
Definitely. Please go
Hello,
ahead.
everyone. Yeah, thank you. It's my pleasure to introduce our 10th TUGS India Academic Program today, which we are running on every second Friday evening on TUGS Zoom platform, which is usually based on the gastrointestinal theme. But this time we are coming with an offbeat topic of thyroid nodules with expert team of head and neck and endocrine surgeons as well. Let me introduce the TUGS first to all first-timer attendants. So TUGS is an international surgical society which is based in the UK, which runs various voluntary academic activities on the virtual platform and conducting multinational research activities as well. Those who have not yet joined TUGS, they should join it as it is free and easy to join, and it may help to get updated in various educational activities. With that introduction of the program, now I shall invite our today's team, starting from with our esteemed panelist who took time to join with us. So our first panelist is Professor Jatin Shah. He is the chairman, head and neck oncology services in Memorial Sloan Kettering Center in New York. He is one of the pioneers in the world for the head and neck surgery who started his learning from India, and now he is shifted to US for the surgical training. Afterward, he became a name in head and neck surgeries who gave us the classification of the neck nodes level. He's running online fellowship with collaboration of IFHNOS as well as for the head and neck surgeries. So welcome to TUGS platform, sir. I hope we shall get enlightened with your input in this program.
Thank you very much.
Our next panelist is Country Director, Head and Neck Oncology Services in SCG Cancer Center in Bangalore, Dr. Vishal Rao. He has been known for his innovative voice prosthesis called the OM for total laryngectomy patients, and he made the availability of this cheaper prosthesis to those voiceless people for whom expensive products were out of reach. Our third panelist is Professor and HOD, Head and Neck Oncology Department from Tata Memorial Hospital, Mumbai, Dr. Devendra Chaukar. Both Dr. Vishal Rao and Dr. Chaukar are also running observership for IFHNS and training a lot of fellows in head and neck oncology at their respective centers. Welcome to the panelists. Now I hand over to my co-host, Dr. Bhushan, to introduce our first speakers and their topic without doing any delays. Dr. Bhushan, over to you.
Good evening. Thank you, Dr. Vikas. I would like to introduce the first speaker of today, Dr. Anupti Sood. She is a pass out from AIIMS Delhi. She has done her MCH in breast and endocrine surgery, and she's now a consultant at CK Birla Hospitals, Jaipur. And also she has been a great mentor for me in my surgical oncology training program at Jaipur here. Over to you, ma'am.
Thank you very much, Dr. Bhushan, for such a kind introduction. I am Dr. Anupriti Sood, breast and endocrine surgeon. I have passed out from AIIMS Institute in Delhi. So first of all, I would like to thank everyone and TUGS especially for this opportunity to talk in front of such big stalwarts. Today, I will going to talk about management of benign thyroid nodule. So starting my presentation is on management of benign thyroid nodule. So in this figure, as we can see, goiter is not something very new. It had been there since very long. Earliest evidence of goiter had been in 3000 BC. So topics that we will cover in this presentation is definition of thyroid nodule, epidemiology, classification, clinical approach, investigations, TSH, like TSH, USG neck, FNAC thyroid scan, thyroid incidentalomas, benign colloid cyst, non-surgical management of benign thyroid nodule, and conclusion of this presentation. So to begin with, first, the definition of thyroid nodule. Thyroid nodule is a discrete lesion within the thyroid gland that is radiologically distinct from the surrounding thyroid parenchyma. It does not reflect a single disease. It is basically a clinical manifestation of the wide spectrum of different thyroid disease. So the aim of diagnostic approach is to differentiate between benign and malignant thyroid nodule and to select an appropriate surgical procedure. Coming to epidemiology. In large population studies, about 5% of the subjects have palpable thyroid nodules, but autopsy studies reveal about 49 to 57% of prevalence of thyroid nodules in general population. By high resolution ultrasound, it detects thyroid nodules in 19 to 67% with higher frequencies in women. Frequency in men is to men is 4:1. It is more common in women. So coming to new nodules rate is about 0.1% per year. It is higher rate 2% per year if there is radiation exposure. And thyroid cancer is 1% of all the new malignant disease that are diagnosed. So classification of the thyroid nodule basis of the cause of the thyroid nodule, whether it is benign or malignant thyroid nodule. So benign thyroid nodules are like multinodular goiter, colloid adenoma, Hashimoto thyroiditis, cysts, follicular adenoma that can be macro or microfollicular adenoma, Hurtl cell adenomas. And malignant thyroid nodules will be like papillary carcinoma, follicular carcinoma, medullary carcinoma, anaplastic, primary thyroid lymphoma, and metastatic carcinoma. But in this presentation, we will only focus on benign thyroid nodules. The clinical approach. What will we do if we have a patient with thyroid nodule? What should be our clinical approach? So first, history and clinical examination should be done, a thorough history and thorough clinical examination. And after that, a biochemical examination of TSH. We should find out what is serum TSH level. And whether TSH is normal or it is elevated, then we will go for thyroid sonography, this sonography neck. On the basis of the thyroid sonographic features that we will discuss later on, whether it is high suspicion, intermediate suspicion, or low suspicion, we will undergo FNAC of the thyroid nodule. Depending upon the size, whether more than 1 centimeter, whether FNAC is actually indicated or not indicated, and according to the Bethesda staging, we will ultimately find out whether it comes under benign category or it comes under malignant or suspicious for malignancy category. Now, while taking history, age is very important because risk of cancer are higher with extremes of age, less than 20 and more than 60 years of age. And other important information that we should seek while taking history is exposure to ionizing radiation, whether any treatment of Hodgkin lymphoma had been undergone or treatment of acne or hemangioma, for which ionizing radiation was given to neck, or there is any family history of thyroid carcinoma in a first degree relative, or there is any of history of syndromes like Fab syndrome or Gardner or P10 syndrome or MEN 2A, 2B syndrome in the family. Now coming to physical examination. Physical examination, starting from the vital signs, everything is very important, like taking heart rate and BP and weight. From that level, we should take the physical examination. General examination is very important to find out whether the patient is hypothyroid or hyperthyroid or whether have any thyroid features. Physical examination should also include eye signs showing hyperthyroid eye signs like stare, lid lag, exophthalmos, tremor, tachycardia, and cardiac signs like tachycardia and systolic hypertension. Sensitivity of physical examination is variable in detection of thyroid nodule. In one study by Brendel et al., they have shown that 38% is the sensitivity of physical examination in any thyroid patient. Now, what should we see in inspection and palpation of neck? It should provide information of size and symmetry of the thyroid, of the nodule, whether it is solitary nodule or multiple nodules, multiple nodular goiter is there. What is the consistency of the nodule, fixation to the surrounding tissue, tenderness of the nodule, presence of tracheal deviation or absence of tracheal deviation, and whether it is associated with cervical lymphadenopathy or not. Now, physical findings that are indicative of possible malignancy are nodule with firm or hard texture on palpation, fixation to surrounding tissues, vocal cord paralysis, and cervical lymphadenopathy. Now coming to the next step, that is biochemical evaluation, like finding out what is serum TSH level. If serum TSH level is low, it shows that is hyperthyroid state, and it suggests autonomous thyroid hormone production, that is hyperthyroid state. Patient with high TSH, they have hypothyroidism. In patients of hypothyroidism, we should find out the circulating titers of thyroid autoantibodies like thyroid peroxidase antibodies, thyroglobulin antibodies, to rule out Hashimoto thyroiditis, as thyroid peroxidase antibodies are detectable in 90% of the patients with Hashimoto thyroiditis, and thyroglobulin antibodies, they are detected in about 20 to 50% of the patients. Thyrotropin receptor blocking antibodies, they are found in up to 10% of the patients with Hashimoto thyroiditis. Now coming to ultrasound, which is very, very important in diagnosing or in assessing a patient with thyroid nodule, it is imaging study of choice in the evaluation of thyroid nodule. Thyroid nodule can be hypoechoic, isoechoic, or hyperechoic. And it provides measurement, basic measurements of what is the size of the thyroid gland per se, number of nodules, whether one or multiple nodules, what is the size of the nodules, and basic differentiation between whether it is a cystic nodule or it is a solid nodule. So this is a common normal thyroid that looks on sonography. So this is a trachea. Around trachea, there are two lobes of thyroid gland. We will start with isthmus, then we will see two lobes of thyroid gland. We see the measurements like AP diameter, transverse diameter, and longitudinal diameter, and the surrounding structures like strap muscles, common carotid artery, internal jugular vein, esophagus, whether there is any infiltration into these or not. So when it comes to nodules, we'll see whether there are one nodule or multiple nodules, and we will also examine the nodal regions of the neck are also important. Thoroughly 1 to 6 level nodes should be examined to see whether there is any cervical lymphadenopathy or not. Now, features in ultrasonography, we should briefly cover up the features in ultrasonography that is important, that directs whether it is benign nodule or it is a malignant nodule. So coming first of all, we will start with margins. Margins like benign nodules will have a well-defined margins and with a peripheral sonolucent halo. And this is the case in 60 to 80% of the benign lesions. They have peripheral sonolucent halo. But in malignant diseases, it is like they are poorly defined and irregular nodules. Risk of malignancy is greater when the halo is incomplete. Malignant lesions, they are mostly solid, but some 30% of papillary cancers, they can demonstrate a cystic component. Benign colloid nodules are commonly partly cystic and partly solid. Coming to ecogenicity, most thyroid nodules are hypoechoic, both benign and malignant, whereas hyperechoic nodules tend to be benign, 4% risk of malignancy, and isoechoic lesions, they have an intermediate risk of malignancy of 26%. Calcification, there can be multiple types of calcification, but when calcification is fine and punctate, it may indicate calcified pneumoma bodies that is associated with papillary carcinoma. But when it is heavier, coarser calcification, they are generally associated with benign lesions, particularly long-standing colloid nodules. So there are different types of calcification, but the calcification that are associated with benign lesions, they are inspissated colloid calcifications and peripheral calcification. But if there is a break in the peripheral calcification, then we should think about malignant change in an underlying multinodular goiter. Now coming to comet-tail sign. Comet-tail sign is particularly seen in benign colloid nodule, which represents the clumps of colloid material. Doppler examination is also important while doing ultrasonography because it will show the vascularity. If it is increased or hypervascular, then the indication is towards Graves' disease or hyperthyroid state. And peripheral blood flow is generally seen in benign lesion. And malignant lesion would also have increased and hypervascular internal blood flow. But peripheral flow is seen in benign lesion. Now, how will we differentiate? How will we score these features? So there is a scoring system of ACR, American College of Radiology, Thyroid system. It is more or less similar to BI-RAD system. So thyroids, 1 is normal thyroid gland, 2 is benign lesion, 3 is probably benign lesion, 4 is suspicious that can be subclassified as 4A, 4B, and 4C. 5 is probably malignant lesion, and 6 is biopsy proven malignancy. So on the basis of different characteristics like composition, ecogenicity, shape, margin, and ecogenicity, they have different features have been given different points. And on the basis of these points, whether it is 0.2, 3, 4, or 7, they can be classified as thyroid scoring 1, 2, 3, 4, or 5. So on the basis of these points and these different characteristics, we can say that whether it is thyroids 1, 2, or 3, or 4. Now coming to the size of the lesion. If it is thyroids 3, like mildly suspicious, then every Thyroid 3 lesion should not undergo FNAC. FNAC is recommended in only Thyroid 3 lesion if it is more than 2.5 centimeter, and follow up if it is more than 1.5 centimeter. In less than 1 centimeter, nothing is required. Similarly, if it is Thyroid 4 or highly suspicious, then FNAC should be done in smaller lesions, like even in less than 1 centimeter lesion. Now, ATA, that American Thyroid Association, recommends that follow-up should be determined on the risk stratification based on ultrasound pattern. If there are high suspicion ultrasound features that we have already discussed, then the repeat ultrasound and, if required, FNAC should be done within 12 months. If it is low to intermediate suspicion, then at 12 to 24 months, that is 1 to 2 years. And if it is very low suspicion, then more than 24 months or more than 2 years. Now, this is very important, FNAC. When should FNAC be done? In all cases of thyroid nodule should not undergo FNAC, depending upon the sonographic findings. Like if sonographic findings are like purely cystic or spongiform or mixed cystic or solid, then FNAC indication is less, that we should might not require FNAC in these cases because thyroid score is low, either 1 or 2. But if the ultrasound findings are showing highly suspicious features like abnormal lymph nodes, extracapsular invasion, or any other suspicious feature, then FNAC should be done because it will become thyroid 5. So FNAC should be done even in smaller lesions. Now, most patients with suspicious subcentimetric nodules can be observed. Like less than 1 centimeter, generally we do not follow, or generally we don't do anything about them. They should be observed, but only in selected patients or in other exceptions where nodules are less than 1 centimeter. In these cases, FNAC should be done. What are the exceptions? Like strong family history of thyroid cancer, known syndromes associated with thyroid cancer, young age of the patient, history of therapeutic childhood head and neck radiation, or preference of the patient for FNA over observation. So these are important. These are exceptions where even less than 1 centimeter nodule should undergo FNAC. Now, what is the Bethesda system? Bethesda system for reporting, this is the 1, 2, 3, 4, 5, 6 category of Bethesda system. 1 is non-diagnostic or unsatisfactory, that we need a repeat FNAC in Bethesda 1. Bethesda 2 is benign. Bethesda 3 is AUS or FLUS, that is follicular lesion of undetermined significance. Bethesda 4 is follicular neoplasm. Bethesda 5 is suspicious for malignancy, and Bethesda 6 is malignant. So we'll discuss all these in detail now. So Bethesda system, if it is category 1, the risk of malignancy is 5 to 10% because it is little higher than benign because the sample is not sufficient. It is unsatisfactory sample. So repeat FNA is recommended. But in benign lesion, benign Bethesda 2, the risk of malignancy is only 0 to 3%. So clinical and sonographic follow-up is sufficient. In AUS, that is Bethesda 3, ATP of undetermined significance, the risk of malignancy is 10 to 30%. So the usual management is either do repeat FNA, molecular testing, or surgically lobectomy we can do. Follicular neoplasm or suspicious, they have little higher risk of malignancy, molecular testing or lobectomy. Molecular testing to find out whether it is BRAF or malignancy is there or not, or any genetic mutation is there. That we can be, I think the malignant speaker will deal with all these. Now, the suspicious for malignancy, Bethesda 5 and Bethesda 6, they have higher risk of malignancy. So the treatment will be near total thyroidectomy or lobectomy, depending upon the size of the lesion. There are other reporting of thyroid cytological, other reporting systems also, like Italian Consensus 2014, Bethesda, and there is UK reporting system also. They are more or less the same. They have similar 1 to 5 or 1 to 6 staging to differentiate between non-diagnostic, low risk, high risk, and suspicious for malignancy. There are other staging system also. So coming to FNAC in little detail. So what is an adequate sample, and when we consider it as non-satisfactory or inadequate? Adequate sample, the criteria for adequacy is at least minimum of 6 group of cells, at least 10 cells per group, preferably on a single slide. But when it is not there, then it is considered as Bethesda 1. that is non-diagnostic or unsatisfactory, like fewer than 6 groups or poorly prepared slides or poorly stained, or only we could aspirate cystic fluid. Then in these category, these cases we will label as Bethesda 1. Bethesda 1 will only have RBC, like in this slide we can see, or only skeletal muscle or extensive air drying artifact or cystic fluid and macrophages. Coming to Bethesda 2, when we will label the FNAC sample as benign. This is very important, but we should know that benign results, this is the most common FNA interpretation in approximately 60 to 70% of cases. To classify or to consider it as a benign, it should be either the benign results are further classified as benign follicular nodule or as thyroiditis. Benign follicular nodule, it applies to a cytological sample that consists of colloid and benign appearing follicular cells. So colloid will appear as thin watery colloid. It has thin membrane or mosaic appearance, or the thick colloid will show cracks. Now, benign follicular nodule will have monolayered sheets of follicular cells, and the follicular cells, how will they appear? They will appear as delicate cytoplasm with ill-defined borders, with finely granular chromatin, and inconspicuous or absent nucleoli. Now, benign disease like Graves' disease. Graves' disease will all have follicular cells and colloid, and apart from this, the flame cells, they are very distinctive for their marginal cytoplasmic vacuoles with red to pink frayed edge. So this is particularly peculiar for Graves' disease. Now for lymphocytic thyroiditis, as the name suggests, yes, sir?
We have 5 minutes more.
Okay.
5 minutes more.
Okay. So in lymphocytic thyroiditis, as the name suggests, it will, apart from follicular cell, it will have lymphoid cells and follicular cells and Hürthle cells. In acute thyroiditis, as it's seen in immunocompromised patient, it will have neutrophils and necrosis and very few follicular cells. In granulomatous decurvane thyroiditis, it is a self-limited limited inflammatory condition. They have granulomas, as the name suggests, and multinucleated giant cells. Renal thyroiditis, it has more of fibrosis and acellular smear, and colloid and follicular cells are generally absent. Bethesda 3 AUS or plus, they have architectural or some features of nuclear atypia like nuclear enlargement, pale chromatin, irregular nuclear contours, nuclear grooving, prominent nucleoli, and elongated nuclei. Architectural atypia like clusters of follicular cells and almost entirely microfollicles form. Bethesda 4 follicular neoplasm, they have altered architectural pattern characterized by significant cell crowding or microfollicle formation. Bethesda 5 suspicious for malignancy, they have like most common malignancy is PTC, papillary thyroid cancer. So it will have papillary architecture and nuclear alterations with nuclear changes of intracytoplasmic nuclear inclusions, nuclear grooves, powdery chromatin, micronucleoli. And cellular swells are very highly characteristic of PTC. Now coming to other investigation of thyroid scintigraphy. Thyroid scintigraphy is not indicated in all the patients, and it is indicated in solitary thyroid nodule and multinodular goiter with suppressed TSH level, that is in hyperthyroid state. Large multinodular goiter, especially with substernal extension and ectopic thyroid tissue and some clinical hyperthyroidism. So on thyroid scan, whether it will be colloid, warm or hot nodule, and cold nodule only less than 20% are malignant, in warm 10% are malignant, and hot only 5% are malignant, and rest are benign. What are thyroid incidentalomas? Incidentalomas are incidentally detected with in asymptomatic patient in an unexpected scenario, and they are unnoticed by patient, undetected by physician, and only on imaging or surgical exploration of neck or on whole body nuclear scanning. It is basically a disease of modern technology. So most commonly the imaging that detects thyroid nodules, most common is CT scan, and then it is PET scan and ultrasound. So prevalence of thyroid incidentalomas that are detected on ultrasonography, that has been done for what disease, that is done for hyperparathyroidism. The studies have shown that most commonly if the sonography is done for hyperparathyroidism, then incidentally thyroid nodules are detected. So in incidentalomas, if there is history of radiation of thyroid cancer is positive, then we will go for FNAC. If it is negative, then on the basis of ultrasound features and on the basis of the size of the nodule, whether it is more than 1.5, then we'll go for FNAC. If it is less than 1.5, then only observation is required. Then what is thyroid cyst? It is very commonly found in thyroid sonography. They are usually benign. Only 7% of malignant nodules are truly cystic, and 12% of malignant nodules, they are mixed solid and cystic. So cytology, if it is required, if we suspect malignancy, it is from cyst, fluid, or wall of the cyst. Then what is the treatment? Treatment is generally of thyroid cyst is either monitoring by ultrasound, the following up with ultrasound, or aspiration or surgical treatment. And if there are smaller cysts, then simple aspiration is sufficient. If they are larger cysts or recurrent cysts, then surgery is required. Now coming to the treatment of the thyroid nodules, the first treatment is follow-up, no treatment, wait and watch. If the nodules are benign, very small and asymptomatic, then no treatment is required. If it is large and if it is causing obstructive symptoms like breathing or swallowing difficulty and have suspicious features of malignancy, then the surgical treatment is required. And there is one more treatment, that is radioactive iodine, only in cases of hyperthyroid or hyperfunctioning thyroid nodules and goiters, not in every case. So other non-surgical management are like radioactive iodine, percutaneous ethanol ablation, and percutaneous laser ablation. Only in symptomatic patient. In asymptomatic patient, we don't need anything. We just need follow-up of 12 to 18 months. Then percutaneous ethanol injection. Here, 95% ethanol is introduced, causing shrinkage of the nodule secondary to the coagulative necrosis. Here, multiple injections are required. In different studies, they have shown that at 12-month follow-up, normalization of both TSH level and CT scan findings are documented, but they are usually useful in nodule of less than 15 ml. The best results are obtained for larger or symptomatic cystic nodules, and reduction of up to 50% is noted. Only prospective and randomized trial that have shown that has compared ethanol and saline injection, they have seen the cystic volumes are reduced in 27 to 33 out of 33 cases, in which the ethanol is injected, and 16 of 33 cases in which saline is injected with p-value of 0.006. Percutaneous laser ablation, it is a minimal invasive alternative to surgery, and it is a rapid method, outpatient basis on the under ultrasound guidance. And this should be limited to the treatment of large benign thyroid nodules that cannot be treated with surgery, radioactive iodine, or medical therapy, not in every case. A 50 to 70% decrease in nodule volume is noted after 1 to 3 sessions, and it is the only randomized trial that is available that has randomized 15 patients. They have seen greater reduction in nodule volume from 8.2 to 4.8 ml with p-value of 0.001. Now, if we are going for surgical treatment and the patient is hyperthyroid, then first we have to make the patient euthyroid, either by giving anti-thyroid drugs until T3 and T4 are normal, or by giving inorganic iodine like potassium iodide or iodine solution if it is an emergency and euthyroid state is not possible by other means. Extent of resection is either total thyroidectomy, both the lobes are involved and both the lobes have nodules, subtotal thyroidectomy, or Hartley Dunhill procedure for patients without good access to thyroid hormone. Then we can do subtotal thyroidectomy, and especially in benign cases, so they will not need thyroid hormone replacement. Multinodular goiter, we have to go for total thyroidectomy, and single nodule or single lobe solitary thyroid nodule STN. In that case, is ipsilateral lobectomy or isthmectomy if it is in the thyroid isthmus is sufficient. Coming to complication of surgery, the most common complication is hypocalcemia. It can be transient or permanent, especially in cases of total thyroidectomy. Hemithyroidectomy or lobectomy does not have this complication. Or recurrent or superior laryngeal nerve injury or post-operative bleeding or thyroid storm only in case of hyperthyroid patient. Post-operative management, firstly, especially in total thyroidectomy patients, serum calcium or intact parathyroid hormone levels should be measured, and prediction of calcium levels by 6 to 12 hour post-operative calcium levels, they are very important. Low PTH, intact PTH level of less than 10 to 15, they appear to predict symptomatic hypocalcemia later on. So prophylactic, in some studies, prophylactic calcium supplementation of oral calcium can be given initially and then be tapered off. And if still calcium hypocalcemia persists, then calcitriol 0.5 microgram daily can be given. And patient is discharged if patient is asymptomatic and serum calcium is less than 7.8, is more than 7.8 milligram per deciliter. Thyroxine replacement is necessary in total thyroidectomy patient because we have removed the complete thyroid gland, and it should be on the basis of 0.8 milligram per pound or 1.67 milligram per kg. And serum TSH should be measured 6 to 8 weeks post-operatively, and once stable, then and normal, then once a year annually. So the conclusion is every thyroid nodule must be investigated with serum TSH, USG NEC, and if required, FNAC. Small benign nodule can be followed up with USG NEC, and if required, FNAC can be repeated. Large nodule, rapidly increasing size of the nodule, and the nodules that are causing pressure symptoms should be treated surgically. Newer techniques like radioactive ablation, laser ablation, ethanol injection, they are reserved in selected cases only. Thank you very much.
Thank you, Dr. Anukuti ma'am, for such a crisp and compact presentation. This is a very vast topic to be covered in half an hour, but still you might try to manage everything starting from radiology up to the evidence-based medicine. The discussion and question answers will be discussed at the end of all the 3 sessions. So audience, please hang on and put your questions in the chat box. Now I would like to introduce our second speaker, Dr. Suvendu Maji. He is an assistant professor in surgical oncology at IPGMER, Kolkata. He has many papers in his name. He has also worked at CMC Vellore in endocrine department. His topic for today is malignant thyroid nodules. So the stage is yours, Dr. Suvendu, sir. Unmute yourself, sir. Dr. Suvendu, sir, please unmute yourself.
Am I audible to everyone?
Yes, sir.
Yes.
Yeah. Good evening, ladies and gentlemen, and good evening, the expert panelists. I would like to extend my gratitude towards the TUGS committee who has given me this great opportunity to present an important topic before an experienced and experienced audience. I am Dr. Suvendu Maji. I passed MS General Surgery from Institute of Postgraduate Medical Education and Research, Kolkata, way back in 2015. Following which, I worked briefly in the Department of Endocrine Surgery in Christian Medical College, Kellogg. And thereafter, I joined DNB Surgical Oncology. After which, I passed out and joined Medical College, Kolkata. And now I am currently Assistant Professor Surgical Oncology, working in my mother institute, IPGMR, Kolkata. Today, I would be speaking on thyroid cancer guideline-based management. So, to start with discussion of thyroid cancer, first of all, we have to look into the history because it shapes our present and help us to plan our future. Historical record shows that the treatment of thyroid diseases started way back in 2700 BC and times before that, because there were mentions in the Egyptian texts. Similar mentions of goiter was there in our Ayurvedic texts. The gland, the thyroid gland, was described in the year 1411 by Da Vinci. Then in around 1773, thyroidectomies began to be described. In 1881, Billroth did around 48 thyroidectomies, in which 4 patients died. Cocker from the year 1880 to 98 performed an impressive number of thyroidectomies in those times, with around 1600 thyroidectomies with only 1% mortality. Perhaps that is why he is known as the father of thyroid surgery, and he has Cocker method, Cocker incident, and Cocker maneuver to his name. Thyroxine was with which we treat thyroid cancer diseases was discovered in the year 1914. In 1951, neck dissection, which we often perform, was described, and William Halsted was the first person who described thyroid cancer. So as the timeline suggests, thyroid diseases at those times were mainly dealt by surgeries. Methods were crude and hemorrhage took more lives than those were saved. Medical management was non-existent as thyroid hormone was not even discovered till 1950. And animal extracts were then the main source of thyroid hormone for treatment of thyroid diseases. Coming to the epidemiology, thyroid cancer can happen in children as well as adults. In children, it is a rarer disease and it occurs at a rate of 3 to 5 cases per 10 lakh per year. Differentiated thyroid cancer is the most common type even in the children. In adults, all varieties of thyroid cancers do occur and females are more affected than the males. The median age is around 45 to 50 years. This is reflected in the age standardized ratio where females have a higher rate than the males. Incidence. Worldwide, the incidence of papillary thyroid cancers has been increasing, specifically in the areas where iodinization program or iodine prophylaxis has started. The incidences of follicular thyroid carcinomas or goiters have almost gone down. The most common reasons which are responsible for this increase are detection of incidental Lumas, which was earlier described by the previous speaker, iodine prophylaxis in form of various national programs, and increasing use of ionizing radiation in various diagnostic procedures used for the treatment of disease. One interesting thing about the incidence of thyroid cancer is although the incidence of thyroid cancer is higher in females than the males, mortality is more in males than in females. Thyroid cancer occurs with different rates in different countries. The rates vary in between countries, continents, and even within the countries. And this pattern influences cancer care and the surgical care received by the patients. The incidence is reported to be higher in developed countries. Our Indian side, India, although has a low prevalence of thyroid cancer and the age standardized ratio is about 5.4 versus 6.7 as compared to other countries. In India also, the trend is of increasing nature, and there is obviously a north-south divide in the incidence rates. The southern states, as shown by our registries, have got a higher incidence rate. Now, coming to the classification of thyroid cancer and their incidence, this is the classification that usually we follow. Differentiated thyroid cancers, which includes papillary, follicular cancers, and then medullary, undifferentiated cancers, anaplastic, and other rarer varieties like lymphomas and metastatic tumors. However, WHO classification is much more detailed and gives us the direction on how to classify the tumors. When WHO classification is considered, the 4th edition was published in the year 2017, which when compared to 3rd edition shows many new changes. In this 4th edition, molecular and genetic characterization of follicular derived thyroid tumors were included. A new classification for encapsulated well-differentiated follicular tumors was introduced. A new category for borderline malignant tumors of uncertain malignant potential was introduced in this edition, 2017 edition of the classification system, and separate ICD codes were used for different variety of thyroid tumors. The follicular thyroid carcinomas and the papillary thyroid carcinomas have been reclassified in greater detail, which we will see in the subsequent slides. So this is the WHO classification at a glance, and which shows the broad spectrum classification of WHO. The papillary thyroid cancer. The papillary thyroid cancer the term was coined in the year 1974. It says that PTC is a malignant epithelial tumor containing papillary structure regardless of the nuclear features. In the second and the third edition, the nuclear features actually became important criteria for classifying malignancy. In the fourth edition, a borderline tumor entity was incorporated to reduce the diagnostic discordance, and a nuclear score guide for RAS type PTC was provided. All these changes were meant to reduce classification of lower risk cancers and their unnecessary treatment. Encapsulated PTC, this was a new variety. Encapsulated PTCs without clear-cut invasion were downgraded to borderline tumor category, which included the two new types, that is WTUMP or well differentiated tumor of uncertain malignant potential, and the NIFTP type. Classification of these new variants into new variants have led to changes in thyroid cancer management. This was the usual varieties which we knew: PTC subvariant, that is the follicular variant of papillary thyroid carcinoma, the diffuse sclerosing variant, and other rare varieties like the tall cell variety or the columnar cell variety, insular variety, and the oxyphil type. A little bit detail about the subtypes. PTC, they have architectural features of follicular thyroid carcinoma, but cellular features of PTCs are present. They are difficult to identify in frozen and FNA sections. In diffuse sclerosing variety of PTC, this mimics Hashimoto's thyroiditis. Often it is associated with elevated antithyroid antibodies, and often they have unfavorable features because they often present as large tumors along with lymph node mets. The tall cell variant or the columnar cell variant, they are often found in the elderly. They often metastasize, and they often fail to concentrate iodine and has poor prognosis. Other varieties are the insular variety, which often mimics anaplastic thyroid carcinomas. The new WHO 2017 edition has led into incorporation of new variants as shown in these slides. Around 15 new variants has been included in the newer classification as compared to what we used to know. Out of which the solid trabecular variant, then cribriform variant, Hobnail variant, all are newer variants which has been included in the new classification system. Other updates: the follicular thyroid carcinoma is now classified into minimally invasive follicular thyroid carcinoma with capsular invasion only, angio-invasive FTC, and widely invasive FTC. The Hurtle cell oncocytic tumor, the change is that the term Hurtle is favored over the term oncocytic, and it is better to use Hurtle cell carcinoma. In poorly differentiated thyroid carcinoma, this term was poorly defined. Now the Turin criteria has been accepted and incorporated into the WHO classification for better classification of these tumors. The anaplastic thyroid carcinoma the term was a bit ambiguous because undifferentiated thyroid carcinomas would often be referred to as anaplastic carcinomas, but now the newer classification suggests that the term anaplastic should be favored over the undifferentiated term. Borderline tumor, this is the newer category in the new classification system. The thyroid tumors are now classified into 3 risk groups depending upon their probability of distant metastasis or recurrence. Those who have a negligible risk, that is less than 0.1%, are classified as benign tumors. Those borderline tumors are those who have less than 1% risk of recurrence or metastasis, and more than that are termed as high risk tumors. Borderline tumors are tumors which are not cancer yet but are equivalent to carcinoma in situ in other organs, they are placed in between follicular adenoma and follicular carcinoma or follicular variant of papillary carcinoma. There are three more prominent and more common type of this follicular tumor of unknown malignant, uncertain malignant potential, then well-differentiated tumor of unknown, uncertain malignant potential, and NIFTP. These are the three variants which now fall into the borderline category. The follicular thyroid carcinoma, I previously discussed this slide. It is classified into three prognostic groups. One is the minimally invasive, encapsulated angioinvasive type, and the widely invasive type. Now in our clinic, the thyroid cancer can have different kind of presentations. So I classified it in the way they present to us in our OPD. In most cases, they present us with nodule. Some people present us with thyroid mass where they are directly referred with a diagnosis of a thyroid mass or a lump in the neck. Some people present with incomplete surgery, which could be that the patient has undergone a lobectomy and the patient has been referred for completion thyroid surgery, or the lymph node has not been addressed, or there is a sizable remnant disease which needs to be excised. Another spectrum of presentation is patient presents with distant metastatic disease evident on their reports, which could be either a pulmonary metastasis, soft tissue metastasis, or any other sites in the body. And the last subset of the patients are those who come in follow-up, and they could be broadly classified into those patients having biochemical recurrence or thyroid plate recurrence or nodal recurrence or any combination of these three. The first part of the presentation, nodule, has been described very well by my previous speaker, and I would only focus on few points which needs to be emphasized. So nodule, as she said, are very common in the general population. The prevalence of the palpebral nodule is around 3 to 7%. Nodules could be either hot or cold, and the cold ones are those which are more concerning and should be investigated. A nodule can have a long list of differential diagnosis, which is given on the table on the left hand side. It could be either a colloid nodule, or it could be a cyst, or it could be just subacute thyroiditis. However, nodules which are suspicious on clinical examination, suspicious on radiological examination, those who have a history of rapid growth or have a history of thyroid cancer in the family, any genetic syndrome, any history of neck irradiation, or nodules presenting in the younger age group or the older age group associated with cervical lymphadenopathy or other compressive symptoms should always be investigated or referred to a thyroid surgeon or a specialist center. So the basic investigation is obviously TSH, which helps us to broadly classify the tumor based upon the thyroid status, and depending upon which the nodules can be classified either into hot nodule, cold nodule. This part has been well discussed further, so I'm skipping. So whatever be the nodule, a malignant nodule should be investigated, and there are two broad investigations. One is the fine needle aspiration cytology, and another is the USG. Previously, the guideline was not to put needle into nodules which are less than 1 centimeter and to FNA nodules greater than 1 centimeter. Sub-centimeter nodules would be sampled only when there are risk factors. Nowadays, the FNAC should be USG guided, and the pathology result is reported in form of the Bethesda system. This category has been already explained in detail. The Bethesda system obviously is a 6-tier system. It has got its own loophole, specifically the category 3 and the 4, where it is still unable to specify the mode of treatment. It could be a lobectomy, it could be a repeat sampling, and that is where molecular tests and diagnostics are actually required. This slide has already been discussed. This is the thyroid system, which gives us a risk scoring, which helps us to classify the thyroid nodule of the SOL into risk categories depending upon its probability of having malignancy and define our management. So this is the American Thyroid Association system, which helps us to re-stratify the nodules into those having high suspicion, intermediate suspicion, low suspicion, and very low suspicion. There are other parallel reporting systems developed by other continent or other bodies like the European Thyroid Association system, the Korean Thyroid Association system, and the NCCN, which is the most common one, which is often used in our clinical practice. The British Thyroid Association all have this 3, 4, or 5-tiered system, which classifies them into various risk categories and determines the sizes where they should be biopsied. This is another such risk scoring system, the AAC, ACE, and the AME system. Now, what is the summary? Previously, all nodules greater than 1 centimeter would be recommended for FNA. However, today, not all nodules require FNA. In general, nodules with very low suspicious US features or sub-centimeter nodules do not require FNA. When the various risk scoring systems are compared, it is found that the ATA and the KTA system offer higher diagnostic accuracy when compared to the AAC, ACE, and the AME guideline, and it is up to the institute, up to the protocol to follow any one of this. Based upon this ATA risk scoring system, there are a certain subset of patients which could be actively followed up without embarking on surgery. These are those patients who are at higher risk of surgery or have higher surgical risk due to the presence of comorbidities or have limited lifespan due to any other reason. So these are the management guidelines based upon the category of the nodule upon Bethesda finding: non-diagnostic, benign, non-malignant, AUS, FLUS, and follicular neoplasm of follicular neoplasm or suspicious for follicular neoplasm. All has been described before by my previous speaker very well. So as a surgeon, we are concerned with this, the follicular neoplasm or those with suspicious features which needs surgery. Now, role of USG neck node evaluation. USG is the mainstay of our treatment, and which helps us to evaluate not only the thyroid nodules, it also helps us to evaluate the nodal basis as well. USG has its own limitation, which is well known to us, that is, it is operator dependent. It cannot detect nodes in the central compartment, and very small nodes which are less than 2 millimeter cannot be picked up well by USG. They are also not useful for nodes present in non-standard areas like in the retropharyngeal areas or in the upper mediastinal lymph nodes. So these are certain features which are helpful in finding out whether the node that is seen on the USG are malignant or not. So presence of calcification, cystic change, abnormal vascularity have higher specificity and sensitivity as compared to other criteria like the size criteria, shape, hilum, or the lymph node. This entire system is reflected upon the scoring system which is shown on this side, based upon which the nodes could be radiologically characterized into suspicious category, intermediate category, normal category. In suspicious category, microcalcification, cystic appearance, vascularity, and hyperechogenicity are the features which should make us think of malignancy. Similarly, the indeterminate and the indeterminate categories are those which have these following features. Now, pseudo FNA neck lymph nodes. Obviously, suspicious neck lymph nodes should be biopsied for confirmation of metastatic disease. ATA guidelines suggest the nodes who have the smallest diameter greater than 8 to 10 millimeter should be put to FNA to confirm malignancy, if that would change management. Next is the TG washout. Although TG washout is a very simple technique and increases the diagnostic accuracy of US FNA, it should be done only when FNA is not very specific or sensitive, specifically where the nodes are cystic or nodes in cases where the case is a recurrent one. The TG washout, what is the limitation? Although it increases specificity, it doesn't have any cutoff and it obviously has false negative results in cases of medullary thyroid cancers or in oncocytic variant of PTC. False positive results can also occur in cases where thyroglobulin antibodies are present or in presence of ectopic thyroid tissue or where central compartment lymph nodes are present. So when using TG washout, that should be individualized and should be carefully used and interpreted in the background of the clinical situation. Now, assessment and staging. For assessment and staging, it is a two-step process. One is the pre-therapy imaging, which often happens before a surgery or a treatment is undertaken, and the post-therapy imaging, which usually denotes the radioactive iodine scan, which is used to detect recurrence or metastasis depending upon the cases we deal. And in some cases, ultrasonography is also the investigation of choice as post-therapy image. In pre-therapy imaging, although in the specific criteria for USG have been laid down, we do not have any fixed criteria where CT and MRI should be done. But most of us would agree that CT or MRI should be done in T4 tumors, invasive tumors, tumors accompanied with bulky nodes, or tumors having a retrosternal component which cannot be clinically assessed. Now, what is the CT criteria for malignancy? CT showing cystic changes or hemorrhagic changes along with calcification or contrast enhancement or a hypoplastic appearance of the thyroid tumor on CT will suggest that probably we are dealing with malignancy. PET CT is in general not recommended, but it may be used full in cases where the risk of distant metastasis is very high, like in anaplastic CA or medullary thyroid CA. Now, for staging purpose, what we use most widely is the AJCC 8 edition. The AJCC 8 edition is a well accepted staging system which gives us the mortality or the risk of mortality associated with different kind of thyroid cancers. Now, this AJCC staging system is a bit different. Why? Because this staging system is different from other staging system because this takes the anatomic extent of the disease along with other factors like age, which are generally not included for other head neck cancers. This staging system, AJCC staging system, is recommended by both ATA as well as the NCCN guideline. The ATA also recommends, apart from the AJCC, other risk stratification system to predict the risk of the disease recurrence or persistent diseases. It is important that this AJCC staging system is mainly meant for differentiated thyroid cancers, poorly differentiated cancers, and anaplastic cancers. Now, medullary thyroid cancers have a separate staging system. It is also important to note that the tumors which arises outside the thyroid gland, like the thyroid cyst and the struma ovary, are not staged with AJCC. Another important point of this staging system is that cytological proof has to be obtained for staging, and it has to be done. The T stage, how to find out the T stage, N stage and the M stage. The T stage is based upon the USG correlation of the size of the nodule or the size of the lesion which is found. The N status can be found either by clinical examination or through the USG assessment as delineated earlier. However, the M stage is not complete until and unless the surgery is complete and post-op treatment, post-surgery radioiodine scans are performed. So the initial staging needs to be restaged after 1 to 3 months of surgery completion. Now, what are the key changes? The key changes are the age has been increased to 45 to 55 years. So many tumors have, which were actually previously classified, they are downstage now. Minor extrathyroidal extension, which was detected only on histological examination, has been removed from the definition of T3 disease. The presence of metastatic lymphadenopathy N1 no longer upstages a patient to stage 3 disease. Now, gross extrathyroidal extension is classified as T3B disease. This table just compares the two staging system of the two editions, 7th edition versus the 8th edition, which shows what I just said. So the TNM AJCC system gives us the risk mortality, the rate of of the mortality associated with the disease and its different stages, but it does not tell us the risk of recurrence and does not classify the disease into the high risk or the low risk, for which we use different other systems like the AGs, AMEs, MASIS, URTC, whichever is suitable. They efficiently distinguish between low and high risk disease. Based upon this line, we also have a ATA system which classifies disease into 3 categories: the ATA low risk category, intermediate risk category, and the ATA high risk category. So low risk patients are those who does not have any local disease or distant disease, have all the tumors resected, does not have an aggressive histology, does not have a metastatic disease on the scan, and have less than 5 lymph nodes upon pathologic evaluation. High risk disease are those who have obviously extrathyroidal extension or metastatic disease, and intermediate risk category is the one which falls between the low risk and the high risk. This stratification system is important because it guides us in the post of management. Now, ATA limitations. ATA has its own limitations, although it is an exhaustive. It requires integration of both pre-op and post-op treatment. Hence, it cannot be applied for decision making just prior to surgery. It is more useful in guiding management during follow-up and recurrence. So, taking the ATA risk classification system and the various AGs, MEs, and MASIS system, all these suggest that none of the risk stratification systems are 100% adequate, and everybody has the shortfalls. So this is reflected in the debate still existing in the management of low risk DTC, whether we would do a lobectomy or we would do a thyroidectomy upfront. Now, management of low risk DTC, it could be either a lobectomy or a total thyroidectomy or active surveillance. The indications of active surveillance I've already discussed. So, lobectomy, the criteria, this is the NCCN guideline. The level of evidence is category 2B, that is not very robust because of the existing debate. So, patients who have a papillary microcarcinomas in absence of history of radiation, unifocal tumor limited to the thyroid, absence of vascular invasion, NIFTP variant, or minimally invasive follicular thyroid carcinoma can be treated with lobectomy. Some other guidelines also suggest that tumors based upon the size between 1 to 4 centimeter and those without any distant metastasis or accompanying cervical nodes can also be treated with lobectomy. Now, what to do with after lobectomy? There could be 2 after lobectomy. Now, if after lobectomy the margin comes positive, if it is a macroscopically multifocal disease, nodal metastasis is present, or it is greater than 4 centimeter, vascular invasion is there, gross ET is there, or if the thyroglobulin do not falls back to its normal level, or there is a structural disease in USG or appearance of cervical nodes which is suspicious, a completion thyroidectomy would be mandatory as per the NCCN guidelines. After completion thyroidectomy, we definitely put the patient on TSH suppression because TSH often fuels the growth of the residual cells. So after low risk thyroid cancer which undergoes completion thyroidectomy, TSH suppression should be done, and the goal of TSH suppression should be around 0.5 to 2 milliunits per liter. In low risk DTC, we do not need any kind of radioactive iodine ablation, and follow-up is only done with USG. This is because after lobectomy, the role of thyroglobulin in assessment of the disease recurrence becomes difficult. Total thyroidectomy, if we face a patient upfront who have multifocal tumor or presence with neck node metastases, or the size upfront is greater than 4 centimeter, straightway we can go for a total thyroidectomy. So total thyroidectomy. So our low risk patients who undergoes total thyroidectomy does not require TSH suppression. Follow-up should be done with thyroglobulin and antibodies every 6 to 12 months. USG is done every 12 months for follow-up. Radioactive iodine ablation is not needed in such cases until and unless the thyroglobulin is not greater than about 5 nanogram per ml, or the thyroglobulin keeps on rising over time. So in low risk DTC who have undergone total thyroidectomy, radioiodine ablation is not needed until and unless these are followed. Now, after surgery, what to do? Where there is an indication for radioactive iodine ablation as per ETA risk stratification, patient has to be put on a
Dr.
low iodine
Suvendu,
diet.
you have to finish in 5 minutes.
Okay. So the patient has to be put on low iodine diet. Patient needs to be put on TSH withdrawal. At about 4 weeks, TSH and thyroglobulin needs to be measured. Now there could be two situations: if the TSH is unelevated or the thyroglobulin level remains high, disease, inadequate surgery or thyroid remnant disease is suspected. In such case, a USG is ordered. If the USG shows a structural disease, it has to be excised or could be ablated as well with iodine 131. However, if no structural diseases are present, then empiric whole body iodine scan can be done. For an optimal iodine scan, a TSH greater than 30 milliunits per ml is required. Now, patient preparation for RAI, there are two protocols. This is the thyroid hormone protocol, and how we stop. 6 weeks prior to radioiodine, T4 is stopped. 3 weeks before radioiodine, that is stopped, and 1 week before iodine, the TSH is checked to see whether it has raised to the optimum point. And just after completion of radioiodine, T4 is restarted. This is the patient preparation with recombinant TSH, which is often used in the Western countries. It is often given in the form of injections, and this is the protocol that is often followed. It is often done, the iodine scan is often done 7 to 10 days after the ablative dose is given. Thyroid dosimetry, what dose we select, what dose we use for thyroid ablation. There are 4 approaches. One is the fixed dose approach, blood or whole body dosimetry, and the tumor dosimetry. Out of all these things, a fixed dose approach is most easily calculated, and it is often used in our clinical practice. For any low risk disease, 30 to 50 microcurie is used. For standard risks, higher doses of 150 microcurie is used, and in 150 to 200 microcurie is used. After one episode of iodine 131 treatment, if there is still elevated PG, around 150 microcurie could be used. And if there is a gross disease, positive margin, distant metastasis, doses up to 200 microcurie is utilized. Now, radioiodine scans. Radioiodine scans could be two types. One is the diagnostic or pre-therapeutic scan, where a small amount of radioiodine is given to find out whether there is a thyroid uptake or a disease elsewhere in the body or not. This scan has fallen out of favor due to the disadvantage of thyroid scanning. What we do is a treatment whole body scan, where a fixed dose of iodine is given to destroy normal thyroid remnant or residual cancer cases. It is generally done after 7 days in all cases where iodine and 131 greater than 30 microcurie is used, and this is often the protocol that I have already shown before. So TSH suppression I have already previously discussed. It has to be done because it is shown to stimulate the thyroid cancer cells. For high risk disease, the level of TSH should be less than 0.1 milliunits per liter. For low risk cases, it has to be somewhere below the normal of 0.1 to 0.5 milliunits per liter. This is the generalized follow-up guidelines. This is also given by ATA, which classifies the response of the treatment in the post-op period. It categorizes into this excellent category, biochemical response, structural response, and the indeterminate response, depending upon which the treatment is given. Thank you.
Thank you, Dr. Suvendu. It was a very insightful presentation, very point-wise made slides. Now, without wasting much time, I would like to introduce our next speaker. He's none other than our Dr. Vikas Jain. He's a consultant surgical oncologist at Akash Healthcare, New Delhi. And not only that, he's now had the new responsibility of leading TUGS India on his own shoulders, and he's doing a commendable job since 2 years and brought TUGS India to the level it is today. Without now, I would like to invite Dr. Vikas Jain to give his presentation on the case capsule of thyroid nodule. Over to you, Dr. Vikas, sir.
Actually, just a small corrections. You have said that it's 2 years, but we are just going to come. And all the previous discussions in the 2 lectures, they have been a very, very exhaustive discussion thyroid nodule. And my presentation is just a summary of the presentation what Dr. Sorry. Is my slide is visible?
Yes, Vikas, it is.
Yeah. So actually in India, we see that the thyroid is not managed. We don't have any specific thyroid surgeons, and thyroid cases goes to overlap between different categories of surgeons. We are in the surgical oncology and general surgeons, ENT surgeons, endocrine surgeons, all are taking care of the thyroid management. So with such a huge discussions, sometimes we also will get confused, and I just wanted to discuss this is a small case to get a straightforward answers for very specific conditions. So I'm coming to my case. Sorry. Okay. This was a 55-year-old female which presented with the left side constant pain in the neck with swallowing difficulty. There was no breathing difficulty. On inspections, the findings was totally normal. When we palpated, neck examination was totally normal. There was no neck node. And this patient has a history of tubercular pericarditis in 2019, and she has taken ATT for 1 year. Now the next question comes to with the neck pain. Clinically, there was no thyroid swellings or nothing in the neck examinations. What investigations we go for? So I just invite my panelists one by one to ask these questions. Shall we start with Dr. Devendra Chokar, sir?
Yeah, so the history is only of neck pain. Is that correct? There's no other symptom. So
Nothing, sir. Only the left side neck pain with some swallowing difficulty.
it's swallowing difficulty, right? So
Yes,
thorough
sir.
clinical examination with investigations of the upper aerodigestive tract to see why this. There's obviously no clinical swelling in the neck, so really there's no external pressure that you're thinking of by your clinical examination and inspection and palpation. Then you have
Exactly.
rule out some other causes which could be causing infection to the swallowing. So that requires a thorough investigations of the upper aerodigestive tract.
Fine. Dr. Suvendu, you want to add anything?
No, that's fine.
Yeah. So for this patient, actually, we have done the upper. This case was under the general physician. So they have done the upper GI endoscopy here, which shows the antral gastritis and nothing in the esophagus, nothing in the pharynx. Then next, what should we do?
So many times these difficulty in swallowing are because of reflux, and you have these little bit of pharyngitis that plays up time and again. So it's maybe a good idea to give an anti-reflux and see if it settles. If especially you find the arytenoids a little inflamed, then you have to rule out reflux in these patients if you're not finding anything else.
Yes, clinically we didn't find anything. Upper GI endoscopy we didn't find anything. We have consulted the patient, and she again and again presented with the similar complaints. And the physicians, because of this neck pain, they have done the ultrasound neck. So this ultrasound neck, we saw it showed that there was a lobulated mixed echogenic as well in right lobe of thyroid for 1.9 centimeter with internal vascularity and areas of macrocalcification within it. 8 mm right side submandibular node was also presented there, and they have tagged it as a Tirard's 4 lesion in the right side of the neck, while the patient was having pain in the left side neck. So what should be the next step? Dr. Anukriti, want to add something? Dr. Anukriti?
No, sir.
What we should do further?
Dr. Shah,
Yeah.
let Dr. Shah come in. He's waiting for a long time.
Thank you, Devendra.
Yeah, I definitely will like the final comments from Dr. Shah. That's why I was asking for this. Yeah.
These patients' complaints are of persistent weight pain. The sonographic findings of the thyroid gland and the neck node do not explain her pain. So I'm not
Yes.
about to embark upon needle biopsies of any of these. I want to have structural imaging, and a non-contrast imaging is useless. And I want to make a point of that, even in the case of thyroid cancer. If you are going to order a CT scan, order it with contrast. It is not a contraindication. At worst, it may delay administration of radioactive iodine by a couple of months, which is not crucial. So I would order a contrast enhanced CT scan and look at the structural detail of the area of her pain and the adjacent organs, vital structures, what have you. So that will be my next step.
So because this is a classical incident flow, as Dr. Shah is mentioning, you've investigated for something else and you found something else which is completely unrelated.
Yes.
And you don't need to chase something which you incidentally found which is not looking malignant. So you don't have to chase this. First, you have to solve why she's having, as Dr. Shah said, if you've not found anything on endoscopy, then you need to see that is there something in the submucosal tissue that is causing pressure, and for that you need imaging.
Yes. So as I said, we need the contrast imaging, and then we have performed the CT neck. And actually the CT neck findings also only the supplementation of the ultrasound neck findings that correlated perfectly with the ultrasound neck. There was no additional information we got from the CT scan. We could see that there was a calcified thyroid mass in the right side of the thyroid lobe. And additional to that, there was some enlarged precarinal subcarinal lymph nodes and right hilar lymph nodes with mild pericardial effusion.
So because we forgot one piece of important history that you given us, that she was a case of tuberculosis. And I have seen
Yes, sir.
tuberculosis node press on the esophagus causing dysphagia in patients, which were thought to be in olden days when they didn't have CT scans, missed to be carcinoma esophagus. So you could miss that, and CT scan would tell you whether she's got a relapse of her tuberculosis and have nodes in the mediastinum or the cervical, pressing on the cervical esophagus, giving rise to these symptoms.
Yes. So, but actually, when in ultrasound, this in upper GI endoscopy, we didn't find any this esophagus findings, and CT scan also didn't give any this relevant finding for this left side neck pain. So we took it actually as this is the reflux gastritis. When she takes the medicine, she get comfortable, and we other than when she got some anxiety issues and she get relapse of this gastritis, and this neck pains also rises again. But if we focus only on the neck pain, should we disregard these thyroid findings also? Or we should do something for this thyroid also?
Well, I think with the gross calcification in the thyroid gland, it is conceivable that she may have had in the past thyroiditis leading to this type of calcification. So I would like to see peroxidase antibodies and thyroglobulin antibodies. If they were not done, they should be done. Occasionally, you will find fibrozine thyroiditis, which can give you chronic pain and a picture similar to what you are seeing on the CT scan. And chronic thyroiditis is known to give you dull, persistent pain, not alleviated by analgesics.
Fine. So actually, this thyroglobulin level, we found that the thyroglobulin level was slightly raised. It was 66.9, and TPO antibodies was normal. Her thyroid functions was also normal. So that's we have discussed many times that's whether we should we have in the previous presentations all we have discussed about the FNACs. I just wanted to ask, sir, why should we don't discuss about the biopsies in thyroid? While I've seen that nowadays that interventional radiologists are doing ultrasound guided biopsies also in thyroid. Dr. Vishal is also there. Dr. Vishal Rao.
Hi, Dr. J. Dr. Vikas, I think the main point I would like to highlight is today there is a lot of interest, and I get a few patients who also come and talk about FNB and talking about looking at more genetic information like FRMA to kind of predict whether the certainty of a nodule, which I think is a gross overkill. I think Dr. Shah was already earlier, and Dr. Chaukar would say that in India, a thyroidectomy would cost as much as that of doing some of these tests. A good pathologist with good fair certainty will be able to correlate the thyroids with the Bethesda. And I think that is what is needed for us is a good good pathologist and who correlates Bethesda with the thyroids.
Vikas, to answer a question, FNAC in 95 to 98% of the time will clinch the diagnosis, and you don't need a biopsy unless the FNAC is not conclusive. It's something like lymphoma or something which you need more tissue, then you do a 5-needle biopsy. But in most of the cases, you will clinch your diagnosis with the FNAC, and that is why that is the first choice of investigation, and we don't do a biopsy of the thyroid.
Right. So here they have done the USG guided biopsy actually, and they didn't find anything, any atypia or any malignancies this thyroid lesion. They didn't find any granuloma also, in view of that we have discussed that she had a tubercular pericarditis also previously. But on the same time, there was a confusion. So FNAC was done, and FNAC shows there was an adenomatoid nodule of thyroid. And with this, thyroglobulin level was also raised. So what we see is that negative findings of this, there was a Tirard's 4 lesion in the ultrasound, and there was an increased thyroglobulin level, but there was no malignancy in biopsy or FNAC. What should we do now?
Thyroglobulin levels in the presence of the thyroid gland has little value. So I would not put much importance on the levels of thyroglobulin when the normal thyroid gland is still in there.
Okay. So what should be our next step, sir?
Well, I think all your findings so far are relatively vague and are not pointing towards a specific diagnosis.
Yes.
Issue is based on the sonographic and imaging studies. Do you want to consider a core biopsy of the thyroid to see if you are getting better tissue, and perhaps send a tissue or material from the core biopsy for molecular studies, although I think it is a little bit too much, and I would be disinclined to jump onto that at this point in the absence of any atypia or anything else. So perhaps a core biopsy may be warranted, largely not to establish malignancy, but to see whether there is chronic thyroiditis.
So because first thing you need to tell the patient is their symptoms don't correlate with the thyroid gland. So these are two different things, and you need to treat it differently. You need to take care of your gastritis or whatever you have, reflux. That's a different issue. Regarding the thyroid, as Dr. Shah mentioned, you need not jump, because now we are getting more and more evidence from Sloan Kettering and follow-up of that incidental observation of sub-centimeter papillary, that you can observe up to 1.52, even if it is papillary. And this is not even papillary. It's thyroid 4, it's negative on FNAC. Again, you can safely tell the patient, get yourself treated, get your swallowing, get gastritis and the reflux treated. We'll observe this thyroid. We'll do an ultrasound after 6 months or 3 months or 6 months. Nothing is lost. There is an increased change in the ultrasound features. We can always do a repeat FNAC. Otherwise, you can keep it under observation.
Hello. सर मैं अभी करता हूँ थोड़ी देर में कॉल. So as Sarah suggested that we have kept the patient for the close surveillance. We didn't put any effort for doing anything, and we have counseled that we should wait and watch. But as we discussed, the patient was admitted for some other reasons like pancreatitis and gastritis, and endoscopy was repeated that time again for the confirming it as enteral gastritis. But she had persistent neck pain on the left side, and ultrasound was repeated. This time they have reported it as a Tirard's 5 lesion with linear microcalcifications in this SOL, and the lesion size was around 2 centimeters. There was no significant change in the sizes from 2020 to 2022. Again, FNAC was repeated, and FNAC was inconclusive. So what should we do now? We should continue with observations, or we can do anything for her?
What about the
I would-
symptoms?
Symptoms is again only the neck pain, sir.
Yeah, so because I would, first tell her that get your pancreatitis. She probably has gallstones as well. I don't know what she had because that fits into the picture of gastritis and pancreatitis. She's probably had these gallstones which are causing both these symptoms. So see, sometimes what happens is because of this incidental finding, the complete investigation gets sidetracked, and you're trying to run after something which is not important and forgetting something that is more important and causing trouble to the patient. So I would let them investigate that, settle that issue first, and then look at I'm not in a hurry to investigate this thyroid any further. I will follow up after 3 months once she's settled and again repeat a sonography. There's a 18-20% discrepancy within the pathologies between thyroid 4, thyroid 5. There's always going to be that inter-observer variation. I don't know whether the same sonologist has performed this sonography after close observation. So
Yes,
that's my
actually, this
call.
point
would like
was
to
I
hear-
wanted to highlight that actually that this thyroid's grading is subjective, right, sir?
Yes.
It's very subjective, and I agree with Devendra. I think we may be getting sidetracked on thyroid while the patient may have other problems to address.
Dr. Vikas,
Sir, yes, Dr. Vishal.
just wanted to add one more point. A lot of the times what we see in our setup is patients who come with this kind of neck pain and who go in for an ultrasound invariably pick up some nodules, but what we have seen is issues like sleep apnea or even snoring and other things actually are some things that we pick up, because of which they actually go into a physician for ultrasound and then end up with thyroid nodule FNAC. So I think there are more to neck pain related things that need to be looked into specifically than thyroid as a reason.
Yes. But when the patient came to us, this pancreatitis and a neck pain that was tackled by the physician, and the patient again and again comes to discuss about this thyroid nodule, that they should what they should go do for this. So that's why actually we have to take decisions on this nodule purpose, not and other symptoms they were taking care with the physician. So this repeated FNAC and patient apprehensions that make us to take her for the hemithyroidectomy in view of this ultrasound findings actually, because what we have been taught that if the biopsy is ultrasound guided biopsy is not doing work, then hemithyroidectomy is the minimum biopsies which is possible for the thyroid nodule. And when we got the final histopathology report, we could find that it was the follicular neoplasm of papillary carcinoma, follicular variant of papillary carcinoma. It was unifocal. It was less than 7 mm lesion. And there was less than 2 mitosis per millimeter square, and all margins negative. Obviously, this is a small lesion, so this is a T1A NX M0 lesion. In intraoperative, we couldn't find any lymph node as well, so it is NX.
Before you go to intraoperative, why does this patient need an operation?
Sir?
Why does she need an operation?
So she was apprehensive after knowing about the thyroid nodule.
Operation is not going to relieve her pain.
I understand, sir.
And this is an incidental sub-centimeter papillary carcinoma, which has no relevance to the need for surgery, the need for treatment, her survival, or the quality of her life. So if she was my patient, first of all, I would not have done a biopsy. And if she came with a biopsy, I would have kept her under surveillance.
Yes, sir. I agree, because if the patient doesn't insist that we should go for some further treatment for this, we could have kept an observation. And these points, that's why I choose this case to highlight these points for this microinvasive type of tumors, very incidental tumors of the thyroid. So even if we got this small, this less than 7 mm lesion, sir, what should we do next?
Do nothing. Send her back to a physician.
Exactly, sir. Exactly.
Now your worry is over. We've taken out whatever that was causing you worry, and now just go back to your physician and get treated for what is causing you the actual trouble.
Yeah, she's already over-treated. There is no need for anything further.
So do we need the surveillance, any surveillance or any follow-up plan of these patients?
So because just to put it in perspective, sorry, so go ahead.
Our plan would be annual clinical examination. And even though she has a lobectomy, We do follow patients with serial thyroglobulins because it is not the single value of thyroglobulin. It is the trending of thyroglobulin levels post-lobectomy which matters. So post-lobectomy, the thyroglobulin will be somewhere between 4 and 10. And we, at a follow-up visit, we do clinical exam and TFTs, TSS, T4, and thyroglobulin. That's our follow-up. We do not routinely do ultrasound on every patient because you sometimes wind up again doing over treatment. You find a sub-centimeter lymph node that will lead you to a needle biopsy. If the needle biopsy is negative, it will lead you to a thyroglobulin washout. Eventually, you will prove it to be a metastatic small node, and the patient will wind up having an unnecessary second operation.
Yeah, so Vikas, to put it into perspective, as you said, after you've done the surgery, just for the attendees, always categorize your patient into the risk group, right? So you put it into low risk, intermediate risk, and high risk. And then you decide how you're going to follow up the patient. As Dr. Shah said, if it's low risk, then you just you clinically follow up. You don't need to do an ultrasound. You don't need to follow up the patient too rigorously, and you don't need very high levels of suppression. If it's intermediate risk or high risk, you follow the protocol for that. So the first thing you do is put it into risk criteria. This is low risk for me. And as Dr. Shah said, you just follow it up with clinical examination and thyroglobulin once in a while, just to see things are under control.
Perfect, sir. Perfect. Thank you very much, sir. It's the only purpose to highlight this case that sometimes for such a small nodules, it is very common for over treatment and undergoing the patients for the hemithyroidectomy. Sometimes even after finding this neoplasm word in the reports, many people are doing the completion thyroidectomy also even in the such a small and low grade tumors. Yes, sir. Thank you.
Because I just want to point that I
Yes.
think this is very good for us to go back again and reiterate about how important counseling can actually avoid a surgery. A proper explanation and counseling can actually make a lot of difference to elevate the fear of these patients and unnecessarily create the panic using the C word, especially in a case like thyroid. I think is being overdone today. And I think this is a good case to show how we can actually work towards preventing such cases by doing good counseling.
Yes,
You're
sir.
absolutely right, Vishal. Also, if you permit me, I want to make a comment on our two speakers. Both of them gave very eloquent and detailed and nice presentations. Unfortunately, they didn't have enough time to go into the details of what they wanted to share. But I do want to make a comment on the presentation by Dr. Sood about the surgical procedures in the event of suspicious or proven thyroid cancer. And Anukriti, you mentioned the surgical procedure would be lobectomy or near total thyroidectomy. Please remove the word near total thyroidectomy. There are only two operations for thyroid cancer. Both are extracapsular operations, extracapsular lobectomy or extracapsular total thyroidectomy. If you do not leave any thyroid tissue behind, and if the patient's postoperative thyroglobulin is below 5, you do not need radioactive iodine ablation, and you avoid unnecessary ablation. The practice of near total thyroidectomy mandates radioiodine ablation because now you are going to have elevated thyroglobulin from the residual thyroid tissue. If you have done an extracapsular total thyroidectomy, your thyroglobulin is not measurable, and therefore that patient can be followed with thyroglobulin without the need of radioactive iodine treatment.
Yes, sir.
There are a few questions in the chat box also, sir. I just want to start with this chat box. So someone has asked why there is a USG finding of taller than wide in malignant thyroid lesion. Any of the panelists can take this question, sir.
So I think this is based on sonographic criteria and a description offered by radiologists, because in general we anticipate cancers to grow concentrically, and therefore a malignant lesion is likely to grow in all directions, all dimensions, and not simply one dimension. In contrast, a nodular goiter, a benign cyst, may be not necessarily concentric, and it will be taller rather than wider, and that is the rationale. But I think it's a very inaccurate description. Based on that, I would not necessarily factor that into the diagnosis of a malignant tumor or not.
So because it's more anterior posterior to transverse diameter that they measure. There are various other criteria which, when they put together, have seen that they are more common in thyroid malignancies rather than benign. And that is why this is one of the criteria that shows that this is malignant. So it's the anterior posterior diameter to transverse. It's just one of the criteria that they found that in malignancy, it's more of this rather than the other. So that's why it's one of the criteria.
Another question is, when should a patient be commenced on thyroxine post total thyroidectomy?
So
I think it depends on how we are following up the thyroid patient. Yeah. Yes, sir.
Thyroxine level washout in the body is not immediate, like parathyroid hormone, which washes out within minutes. So thyroxine will be persistent. You will have reserves in the body, in the liver and the rest of the body, which will last up to 2 to 3 weeks. So it's not necessary that you put the patient on thyroxine the next morning after total thyroidectomy. But within a week, if you start the patient on thyroid replacement, that is appropriate. It is not crucial to start immediately.
Right. Again, because it depends on whether the patient, which category, if it's a high-risk patient, you're definitely going to give radioactive iodine. And how are you going to administer radioactive iodine? If it is going to be recombinant, then you can put the patient on Ultrasound. But if you're not going to use the recombinant, where most of our patients, we use the withdrawal method, then you keep the patient hypothyroid. In 3 weeks, you check it, 60 to 70% will attain a level of more than 30 in 3 weeks, and you can go ahead with the radioiodine therapy. So again, whether you're going to give radioiodine therapy or not is makes a decision, at least in our scenario, because we don't use recombinant TSH that often as we are supposed to use.
Dr. Anukriti, you have shown that in the in the follow-up this hypocalcium management, you have said that vitamin D3 and calcium supplementations. Does the vitamin D3 single dose is sufficient for the hypocalcemic patient, and is it required for the hypocalcemic patients?
Sir, vitamin D is always combined with the calcium. So Shelcal that we give 0.25 microgram of vitamin D with 500 milligram of calcium. So that is already combined. But that has been seen that if there is persistent hypocalcemia, then we can add rocatrol, that is active form of vitamin D, that sometimes help in the absorption of calcium. We are giving calcium along with the vitamin D. So that will help in the better absorption of the calcium, and the patient can come out from the hypocalcemic state. So that is the role of the active form of calcium. That's what it is.
How much dose you prescribe for the vitamin D3?
D3, generally we don't give rocatrol, that is calcitriol. We give generally vitamin D, and this is polycalciferol, that is Shelcal, that is we give 500 milligram and 0.25 microgram combination of calcium Shelcal. But if the hypocalcemia is there, then we can give up to 2 to 4 grams of calcium per day, and then we can taper it off accordingly.
So if we increase the dose of the calcium, then we should increase the dose of vitamin D3 also?
Yes, sir, that will help in the absorption. We should stop pantoprazole because that has been seen with that interferes with the absorption of calcium, and can start rocatrol.
Another question is for Dr. Shah, that sir, will you recommend molecular analysis in Bethesda 5 patients, as 20 to 25% may not have malignancy? So
remember, all the fancy molecular testing is expensive. And
yes.
It is going to be of value in only those patients where you are truly puzzled. In most patients, sonographic findings, patient's age, cytology report, and the size of the nodule will determine whether the patient needs surgery or not. To give you an example, if I have a 3 centimeter nodule in a 65-year-old patient, which is Bethesda category 4, I'm bringing even one grade down. I don't need molecular analysis. Regardless of that, that patient is going to have surgery. So I don't think you need, and also remember, the molecular analysis does not give you yes or no answer. It only gives you percentage probability of cancer. You can give percentage probability of cancer simply looking at patient's age and the sonographic findings. So you don't need to spend $2,000 to do molecular analysis to give you percentage probability of cancer. Having said that, the negative predictive value of the test is high. So if you truly have concern and if you're planning not to operate, and if your patient comes from a wealthy family who can spend that kind of money, you can do the test and say that, look, even on molecular test, I don't think it mandates the need for surgery. So its negative predictive value is high. But in routine practice, I would say, I do not recommend the need for molecular testing. In fact, in New York, people have money, but I seldom, very rarely order molecular testing on cytology specimen.
So because all the reports on molecular testing are mainly to look at the accuracy, the sensitivity, specificity, positive, negative predictive value, most of the reports. If you look at their application in clinical outcome, you will see most of the reports say that less than 10% of the cases it changes what your clinical findings tell you. So it really doesn't impact your management, Dr. Shah said. And the most common you'll use is, or whenever you'll use the rule out test, to prevent surgery rather than using the rule out test.
Sure. Dr. Bhushan, you want to ask something?
Yes, sir. I thought of, I came a thought in neuroendocrine tumors and other tumors, we have various isotopes where we bind them with PET scan and use PET scans. And why do we use a SPECT scan in thyroid and not a iodine PET scan as commonly as other tumors? Am I clear or should I make it?
Bhushan, I think I'm sorry earlier, just to, I think, start with the discussion, if you look at isotopes, the evolution of isotopes and radioisotopes and radiopharmaceuticals has been a complex journey. And most of the ready ones that are available, I have been able to solve the thing for diagnostic purposes. Therapeutic targets has been a different discussion, but for diagnostic purposes, the gold standards have been simple, very easily accessible, and that's why there was no need for us to search for newer isotopes. However, there are a lot of ongoing studies on iodine tagging, PET-related isotopes that are being developed and which are in the pipeline, which have not yet been used as standard because the standard of care is very simple, easily accessible. I think that's where I would start, and maybe Dr. Shah and Devendra sir can add and guide on this.
Even in diagnostic isotope imaging, it is very inaccurate. Diagnostic thyroid scan, iodine scan is not accurate for poorly differentiated carcinoma because you don't have the iodine importer in the cancer cells. So I would rely more on structural imaging than isotope scanning. We do isotope scanning post-therapy rather than for diagnosis.
Yes, sir.
I think we have finished all the questions and discussions.
Sir, I have one.
Yeah. Yes.
Sir, about the molecular testing that BRAF we generally do for PTCs. So BRAF had been seen with low uptake radioactive ablation. They have less avidity for radioactive iodine. So by knowing that that patient is BRAF positive, so we can think in a manner that radioactive iodine might not help in these cases. So that can affect our management. Like MTC, we know that radioactive iodine will not affect. So the only treatment we have is surgical management. So by doing these BRAF testing and all, that can, in one way, it can help the management. It can redirect our management.
You are bringing a very good point. But BRAF positivity is not going to impact upon therapy of differentiated thyroid cancer. The treatment for that is surgery. And in selected few patients, follow-up radioactive iodine treatment. The BRAF V600E is helpful in poorly differentiated carcinoma or anaplastic carcinoma, where if the tumor is BRAF positive, then we now have drugs. we have drugs now that can be helpful and impact upon therapy. The most recent experience is in anaplastic carcinoma with dabrafenib and trametinib in BRAF positive tumors, which has shown dramatic regression in fair number of patients, allowing surgery to be performed and pushing the median survival from 7-8 months to up to 2 years now. But you would not want to do that in papillary carcinoma, or, for example, a 1 centimeter sized or 2 centimeter sized intrathyroidal tumor where you have Bethesda 5 diagnosis. You are wasting your money. That patient needs straightforward surgery. But if you have a 7 centimeter tumor fixed to the strap muscles, there into the trachea, and your cytology shows, not atypia, but poorly differentiated carcinoma. Yes, I want that for BRAF testing, because it will help me to decide whether I can use induction treatment prior to surgery or not.
Thank you, sir.
Anything, Dr. Suvendu, you want to discuss anything?
No, thank you. The discussion had already been done.
I think we can conclude the session now. Dr. Bhushan, you can take over for conclusion.
Yeah. I would like to thank all the speakers for the insightful presentations and all the panelists for beautiful and enlightening remarks. Before closing this session, I would like to share a screen and give a PPT, small PPT for the next presentations which we are going to have. Just a minute. Can you see my screen?
Yes.
So we are going to have we are having 2 upcoming symposiums in the next 2 months, the 11th and 12th. The first one on pancreatitis, it's on the 12th of August, and the second one on pancreatic cancer on 9th of September. Both will be on the second Friday of every month at 8:30 p.m. And for those who are new on this symposium, we have a TUGS India WhatsApp group. You can use this QR code scanner and scan this QR code to join the group for further updates and discussion in the group. Also, we have a Twitter channel. You can scan that code for joining the Twitter channel too. Now, I would also like to thank the TUGS India Chief, Dr. Vikas Jain, for holding such beautiful symposiums, and the patron, Dr. Kamal Mahawar sir, for giving all of us such opportunities. Thank you so much. Good night all. Thank you.
Thank you, Bhushan.
Good night. Thank you, Bhushan, and thank you, Vikas. Good night, Dr.
Thanks, sir. Thanks for your presence. Thanks a lot.
Thank you, Devendra sir.
Bye, Vishal. See you.
Bye.